Hi everyone, and welcome to the first tutorial. I'm Paolo Tarantino from Dana-Farber Cancer Institute, and please join me in exploring this patient case. So we have a case here of a patient with ER-positive, HER2-negative de novo metastatic breast cancer, and for Jane's first-line treatment, she was prescribed a combination of letrozole and ribociclib, which we know that is the treatment recommended by guidelines, by NCCN guidelines, and usually is a very effective and well-tolerated regimen for these patients. So 3.5 years after treatment initiation, Jane is back to the clinic after performing a radiologic restaining. And a CT scan detects 6 new bilateral subcentimetric lung lesions. So the patient benefited for 3.5 years from the treatment, but apparently now she's experiencing progression of disease. The identification of new lesions suggests a need for reassessment of the treatment plan. All right, that's great to see that there's a lot of concordance in the answers to this question. Considering all factors such as disease burden or the status of certain biomarkers like ESR1, PIK3CA, or even emerging biomarkers, and then performance status of the patient are all crucial in making well-informed treatment decisions. Disease burden plays a critical role in guiding treatment choices by providing insights into the disease severity, characteristics, and of course, the aggressiveness of the disease. In the absence of visual crisis, it is usually advisable to explore and maximize endocrine therapy options for the patient. So biomarker status is equally essential as it directs clinicians toward targeted therapies, enhancing treatment effectiveness. And we know that there's several biomarkers that can really help us understand which treatments is more effective for each patient. And then patient preferences always, of course, matter, and their performance status should also be not overlooked. Shared decision-making, considering diverse patient preferences and well-being impact, guides treatment choices. In Jane's case, the absence of visual crisis and of symptoms suggests exploring alternative endocrine treatment options. Further investigation into the biomarker status is definitely recommended in this case. I can see that there's a lot of debate and discordance in this question. So the ASCO 2023 guidelines advise routine testing for ESR1 mutations when breast cancer recurs or progresses during endocrine treatment, whether used alone or in combination with a CDK4/6 inhibitor. Testing should be conducted using blood or tissue samples obtained at the time of progression, and this is critical because ESR1 mutations often develop in response to treatment and are typically not detectable in the primary tumor. This is very different, for instance, from PIK3CA mutations, which usually are present from the beginning of the treatment path. Usually, I prioritize blood-based ctDNA testing due to its higher sensitivity and also non-invasiveness. It's also good to keep in mind that if not performed earlier, testing for PIK3CA mutation should also be performed to guide further therapy. And as such, blood-based ctDNA was performed in this case for Jane and revealed that she has an ESR1 mutation, one that is pretty common, Y537S. Well, the discordance in the answers that were provided to this poll explains how controversial this field is. 3 clinical trials have been conducted and presented to date, all phase 2 trials that have actually looked at the question of CDKs, post-CDKs. They are called Palmyra, Maintain, and PACE. And actually 2 of them looked at the question of palbociclib beyond progression, the PACE and Palmyra trial, both of them showing that the palbociclib after palbociclib may not be an effective strategy. Both were negative trials, but actually the Maintain trial that mostly looked at ribociclib beyond progression on palbociclib showed a statistical advantage in PFS with ribociclib. It's still unclear, of course, it's a phase 2 trial, a small trial, but intriguing in a certain way. Anyway, based on current trial data available, it is still a matter of debate as whether giving a CDK4/6 beyond progression is beneficial or not. We will have possibly to wait for further trial results, and in particular for post-Monarch and LN3 to understand the answer to this question. And now I would like to explore some treatment options. All right, I can see that here there's a perfect agreement. Chemotherapy is usually considered for patients that have a visual crisis or aggressive pattern of disease progression, but this is usually not the case, and in most cases we try to maximize endocrine treatment options. In some cases we consider, for instance, everolimus added to fulvestrant based on randomized phase 2 trials that are available, but really we have little data after progression on CDK4/6 inhibitors with everolimus. Elacestrant instead, the first FDA-approved oral SERD, meaning selective estrogen receptor degrader, offers improved efficacy and a tolerable safety profile, very similar to standard of care endocrine treatment as seen in the phase 3 EMERALD trial. Post-hoc analysis from EMERALD demonstrate that the therapeutic benefit observed with elacestrant, it kind of depends on the pattern of prior receipt of CDK4/6 inhibitors. And for those patients that receive at least 12 months of CDK4/6 inhibitors before moving to elacestrant, there really was a major improvement in progression-free survival with elacestrant compared to standard of care endocrine treatment. In Jane's case, for instance, with a progression occurring after 3.5 years on CDK4/6 inhibitors and with an ESR1 mutation, elacestrant definitely is a promising option because also, of course, the biomarker is important, and we know that patients with ESR1 mutation in EMERALD had enhanced benefit from elacestrant, and the drug is approved by the FDA for ESR1 mutant tumors. Then there's, of course, other trials and other drugs that are available. For instance, per SOLAR-1 trial findings, alpelisib plus fulvestrant is an effective strategy for patients with PI3K mutant disease, and there was a significant prolongation of PFS in the SOLAR trial, although there was no significant improvement in overall survival. There is no randomized data from the BELIEVE phase 2 trial showing that potentially the PFS that is achieved with fulvestrant alpelisib is non-negligible after CDK4/6 inhibitors, but still we don't know about the overall survival in this setting, and toxicity also remains a concern with high rates of hyperglycemia and rash observed with alpelisib. Thank you so much for your broad participation to this poll. In accordance with the phase 3 EMERALD trial, nausea and fatigue were the most common toxicities observed with elacestrant. Nausea was in general the most common side effects, but it only occurred in 35% of the patients. It was in most cases low grade, meaning grade 1 or grade 2, and grade 3 cases occurred only in 2.5% of the population. Alongside elacestrant, several novel oral SERDs are being developed. For instance, there's camizestrant that has shown some data in the SERENA-2 trial and is being developed further in the SERENA program, but also giredestrant, imlunestrant, for which some data is presented at ESMO, and many of these are in development and are poised to advance the treatment landscape further for this population of patients with HR-positive disease. Camizestrant, as I mentioned, was tested in the SERENA-2 randomized trial and had positive results, meaning there was an improvement in PFS compared to fulvestrant in that trial. And moreover, additional novel endocrine treatment strategies beyond oral SERDs are being tested. For instance, PROTACs or CERANs or a new generation of endocrine treatment are being developed and are showing encouraging activities. So in conclusion, I hope you found this tutorial informative, and I would like to thank you all for participating to it. Here are some clinical takeaways from the tutorial. So it is recommended to perform molecular testing with ctDNA to tailor treatment strategies in case of recurrence or progression on endocrine therapy, because that can allow to understand the biomarker status of the disease and tailor our treatments to a disease profile. Elacestrant is the first FDA-approved oral SERD. It was approved this year by the FDA in January 2023 and is also approved in Europe now. And it offers a promising choice for select patients with ER-positive, HER2-negative breast cancer that harbor an ESR1 mutation. Once again, it's very important to test for this at progression because in most cases it is not present at baseline. In general, oral SERDs are being studied as monotherapy, but also in several combinations. And we do hope that in the future we can advance treatment options and improve outcomes for patients with novel SERDs, novel biologic treatments, and novel treatments in general. Thank you so much for attending the tutorial.